We're going to discuss cervical stenosis management and general concepts about cervical spine surgery, and go over a couple cases at the end. These are my disclosures, which don't conflict with the contents of my talk. So before we talk about things, we're just going to go through some general definitions. Whenever we post a case for surgery, you always have to come up with a diagnosis. And so one of the things that I sort of didn't have a solid grasp of, early on was, what's the difference between cervical stenosis versus cervical spondylosis? It really amounts to the fact that they're both very coexistent. Spondylosis means that there's degenerative disease that's leading to spontaneous fusion and osteophyte formation with disc-based collapse. And very often that coincides with the occupancy of the spaces that the nerves go through. So if you have cervical spondylosis, it's highly possible that you also have coexisting narrowing of the spinal region for the spinal cord and the nerve roots. But they don't necessarily equate each other, but they often coexist. So that's just something to keep in mind, that there's a difference between spondylosis and stenosis, but very often they coexist because the same processes that lead to spondylosis also lead to stenosis. So, and what is myelopathy? It's a functional disturbance of the spinal cord, and myelopathy can be of various origins, and we'll discuss this in further slides. When you look at the anatomy of the cervical spine, it's just like most of the spine. You have your lamina and the pedicles and the vertebral body, and it's important to be familiar with all of these aspects of the anatomy, and we'll look at this in the lab. I think it's important in the lab to pay attention to where the vertebral artery is, because this is obviously the most significant complication that you can, or one of the most significant complications that you can encounter. It's a vertebral artery injury. So again, this is a slide that shows that over time, with the collapse of the disc space, you have evolution of bony growth around the areas where the discs have collapsed. And over time, you develop cervical spondylosis. This patient has coexisting cervical spondylosis and cervical stenosis. So you can see that there is this evolving process as the disc space collapse, and this process very often leads to symptoms that need to be treated. So here's the pathophysiology of the spondylosis. With the dehydration of the disc, you have gradual bulging of the disc. You have a loss of height of the disc. As a result, there is a change in the size of the foramen. So if you can see over here, you see the foraminal height is quite nice and substantial. However, with disc-based collapse, you get a loss of the height. As the disc space collapses and the disc has a chronic bulge to it, the bone underneath the bone adjacent to the disc bulge, that starts to grow and form osteophytes. And so that's why we're drilling away all of this bone during our ACDFs and during our foraminotomies. It's because we're trying to reverse the process of this chronic bulging of the disc. What happens to a disc that herniates and remains in place and is never treated surgically? Very often, most of the disc resorbs, but some of it does not. And the part that remains ends up causing what we call a disc osteophyte complex, which means that the disc calcifies partially, but more importantly, the bone around the disc evolves and grows in the direction of that disc. And that's why we end up needing to do surgery very often. So there's a mechanical stress that induces this bone formation as time passes. This mechanical stress leads to osteophytes, and the uncinate process, which is very often the culprit for the development of foraminal stenosis. The uncinate process hypertrophies, and this needs to be addressed surgically. Furthermore, you can also develop ossification of the posterior longitudinal ligament, which is a common culprit of cord compression from the front. And so all of these things can lead to spinal stenosis. So how about myelopathy? Myelopathy is important. It's not just the stenosis that causes the problem, but it's the physiology of the spinal cord that causes a problem. And so you can have myelopathy due to direct compression. You can have myelopathy that's due to problems with the dynamics of the spine. Is there any instability? You can have myelopathy that's due to ischemic processes that lead to spinal cord symptoms. So all of these processes can lead to myelopathic symptoms. So a congenitally narrow spinal canal is generally less than 12 millimeters. That's just a landmark sort of number to keep in mind. So if the spinal canal in the AP diameter is less than 12, then that patient has congenital stenosis. You can have compression of the spinal cord from congenital stenosis. You can have compression of the spinal cord from hypertrophy of the ligamentum flavum, or you can have stenosis due to subluxation, due to kyphosis, or due to these osteophytic processes that we've discussed in the process of spondylosis. So an important thing to look at in this slide is the distinction between A and B. And so, A is the AP distance of the spinal canal, and B is the AP distance of the vertebral body. One of the things that's may potentially be overlooked in a patient who gets plain X-rays is the fact that in general, in a patient who has no stenosis, that A and B should be roughly equivalent. However, if you take an X-ray, you can appreciate that when A is larger than B, or B is smaller than A, that you will have an episode of stenosis. So this is a radiograph. Who in the audience can tell me which one is stenotic, the one on the right or the one on the left? Yeah. So on the right, you can see that the vertebral body, going from here to here, that vertebral body is longer than this distance from here to here. So that B, when it's shorter than A, that's a sign of stenosis. So you can get an initial impression on a patient in clinic just from X-rays, and that would be a cue visually to get further investigation in the form of an MRI or CT. So it's something useful that sometimes we forget because we get so accustomed to seeing MRIs as the first order of business, that you forget about the utility of X-rays. So again, another depiction of how the anatomy is set up with this disc bulge. You can see a chronic disc bulge results in osteophyte formation, and you get compression of the cord. You have uncinate hypertrophy, leading to both cord and foraminal stenosis. So these patients with myelopathy can have not only myelopathy but radiculopathy in addition due to this location of the stenosis, because it's both cord and nerve compression. A gross specimen indicating the relationship of the nerve root to the uncinate process. You can see that the uncinate process hypertrophies and causes nerve compression. The other important thing to look at in this slide is the fact that the neural foramen, very often when the disc space collapses, the neural foramen is on the more caudal aspect of the interspace. So if you have a patient that needs a foraminotomy, for instance, you're really going to want to try to get at this part of the facet as opposed to drilling off more of this part. So, from when you're starting out, you really want to make sure that what you're getting at is this area right here, because that's what's going to lead to a satisfactory decompression. So there's a dynamic stress that can be, encountered, with myelopathy, and so flexion and extension exacerbates this mechanical stress in the presence of stenosis. So if you have these osteophytes that are present on the in the general vicinity of the spinal cord, those osteophytes may not necessarily cause a bad problem if the patient is in a static position. However, with flexion and extension and day-to-day motion and activity, you can easily get exacerbation of symptoms. And so posteriorly, with extension, the ligamentum flavum will buckle and cause cord compression. With flexion, the osteophytes, can cause further compression, with flexion. So a little cartoon demonstrating this process. You can see that the posterior aspect of the vertebral bodies, where the discs are located, if there is osteophytic disease, when the patient flexes, they're indenting the spinal cord. When the patient extends, they are indenting the spinal cord through the ligamentum flavum. Very often, we forget when we have a patient that comes into clinic and we get an MRI. That MRI is done while they're in a fairly neutral position. And, some of my colleagues at the University of Maryland, they will get that MRI and they'll say, okay, well, there's some CSF in front of the spinal cord, there's some CSF behind the spinal cord. That level doesn't need to be treated. That's not necessarily what I feel, because this process that we're looking at right here is indicative of the fact that we are having a dynamic process here, and that MRI is just one snapshot in that dynamic process in the neutral position. So you may see some CSF in front of the spinal cord, but that doesn't mean that the spinal cord is not getting compressed during the day-to-day life. And very often, when you look at that spinal cord and you see a slight indentation in the spinal cord, even though there's no compression on that slice, the fact that the spinal cord is indented is a reflection upon the chronicity of this disease process, and that that there is something going on at that level, potentially during these extreme positions of head position. So the last aspect of myelopathy that's important to consider is the ischemic aspect, and as you will see, the anatomy is such that you have the anterior and posterior spinal arteries, and if you have ligamentous buckling posteriorly, that can lead to ischemic changes of the posterior columns. If you have chronic anterior osteophytes, that can lead to anterior spinal artery ischemia, and just like any disease process, if there's not adequate arterial supply, that can lead to myelopathy. So what are the signs and symptoms of myelopathy? Gait abnormalities, weakness, proprioceptive loss, spasticity, loss of manual dexterity. All of these are things that we assess in clinic on a routine basis. We look for Lhermitte sign, hyperreflexia, Babinski, Hoffman sign. All of these are things that we check. You want to check for coexisting lower motor neuron dysfunction. Does this mean that the patient has coexisting foraminal stenosis? Or does this mean that the patient has a coexisting neurological disease, such as ALS? Important to check, and rule out other disease processes in all of these patients, because very often these things can be missed. Fortunately, they're not missed very often because they're rare. However, they do exist, and you got to watch out for it. So the differential diagnosis of these disease processes is extensive, and it's important to review the potential causes of these disease processes that can lead to similar presentations. So there are a variety of grading scales for myelopathy, and these are the two popular ones: the Nurek Disability Score and the Modified Japanese Orthopedic Association Functional Score. And these grading scales are being incorporated into more recent papers because there are certain grades of these myelopathic patients that do better than others. And so that's why it's important to be cognizant of the fact that there are grading schemes that may potentially help you predict who's going to benefit from surgery and who's not. Just a little depiction of spinal cord signal. Why does spinal cord signal develop? It's usually an ischemic process, and that can be due to the chronic compression of the arterial supply to the spinal cord in that area, and with a little contusion that develops, or a possible ischemic area that develops. So imaging, can take the form of everything: X-ray, CT, MRI, myelogram, and obviously we're going to image what we need, use what we need to figure out the best way to treat the pathology. Flexion extension films should not be forgotten, because you don't want to fuse an area where you have disc space collapse and then later on realize that the big disc space above the collapsed disc spaces is hypermobile and could be the potential source of the patient's problems. I'll give you an example. Very, very often patients have 5, 6, and 6, 7 degeneration. Those are the most common levels, and that might be the sore thumb on a patient's films. Yet they may actually not be symptomatic from those levels, and they could potentially be symptomatic from the C4-5 level or the C3-4 level. And so it's important to get the flexion extension films to make sure that they don't have a spondylolisthesis at the areas above the spondylosis, because that spondylosis may look ugly but may not necessarily be the cause of their problem. And you got to make sure that you look at the areas that have motion, because those potentially are the areas that are the symptomatic areas. So sometimes EMG and SSCPs can be used preoperatively to assess whether or not a patient is symptomatic, or to rule out other disease processes such as ALS. And EMG is helpful for that if the patient has coexisting upper and lower motor neuron findings. So what about non-operative treatment? This should be the case for the majority of patients that we encounter. Non-operative treatment. This is you take a random sampling of the population in their 60s or 70s. You could easily see findings that would potentially make you think that surgery would be indicated, but always non-operative treatment is the first thing that needs to be attempted. Most cases are not even approved in the insurance company world, unless non-operative treatment has been attempted. So another reason. So obviously, if there's impending weakness and neurological deterioration, then non-operative treatment should not be considered. So these are the general treatment things that we recommend: physical therapy, injections, NSAIDs, risk modification of behavior and to avoid risks. Non-operative treatment can be very different depending upon the patient's age and the patient's tolerance for activity. So what we want to do is we want to stabilize the segments by strengthening the muscle around those segments with physical therapy. That's why physical therapy is prescribed, because you're trying to strengthen the muscle in the areas where there's too much motility and movement. So what about operative management? Obviously, we have a variety of anterior versus posterior versus both, and it depends on where the disease process is located. So it depends on how much of a correction is needed to treat a spinal deformity. It depends on what the patient can tolerate as far as what their comorbidities are. So there are a lot of factors that go into play when you decide what the approach is going to be. And so the location of the stenosis is one of the most critical things to identify. Is the process ventral or is it dorsal? Can this be treated adequately from a one-level surgery? A one-level corpectomy usually can stand alone on its own with a plate. However, once you go beyond one level of corpectomy, circumferential fusion is generally recommended. So a lot of it depends on what you're encountering. Very, very important to look at the alignment of the patient's spine. Are they starting out with a normal lordosis? Starting out with a normal lordosis makes the patient potentially amenable to a laminoplasty if most of the patient's symptoms are from central cord compression. Does the patient have kyphosis? Kyphosis usually means that the patient needs some kind of anterior approach because you need to correct that, and that's most easily corrected through the anterior approach through an anterior release. Is the patient straight? If they're straight, it could be either anterior or posterior, depending upon how much they move on flexion extension film. So very important to incorporate the flexion extension films to help you determine whether the patient has a reducible deformity, because if they do, then it potentially could be treated through a posterior approach as opposed to an anterior. So one of the important things with regard to our discussion of myelopathy that I discussed earlier is the fact that myelopathy is worse when the spinal cord is stretched. And this is a depiction of the degree to which the spinal cord is stretched when the neck is kyphotic. So, and some of the ischemia that can be developed during the myelopathic process is due to this stretch. You can imagine a stretched artery is going to be less capable of perfusing the capillaries in the spinal cord in comparison to an artery that has no stretch. And so you can see in Figure C, the distance between those little dots on that on the thecal sac is shorter than the distance between the dots in A. In A, those dots are being stretched out. And so you can see how that dynamic process is very relevant. And that's why patients do better when you correct their kyphosis, because their spinal cord is not getting stretched. So another important thing with regard to stretch is to not over-distract when you do an ACDF, for instance. If you over-distract, you're stretching the spinal cord, and that should be avoided. It's important to look at the lateral X-rays, and very often we do distract in order to facilitate the decompression, but you should not put in an interbody graft in that 100% distracted position unless the facet joints are lined up and are touching each other posteriorly. So it's important to check your radiograph before you put your spacer in to make sure you have not over distracted. So, standard principles of anterior plating, you want to keep your plate as close to the disc space as possible to avoid adjacent segment degeneration, and maybe a potential indication to use a zero profile device if the patient has just a one-level disease process. And so, what are the goals of posterior stabilization? We basically are replacing the posterior tension band. And in a patient with a flexible deformity, you can treat multiple segments fairly efficiently through the posterior approach. And so there's an evolution of these posterior stabilization techniques. It started out with wiring, which eventually led to these clamps, later on to plate rod constructs, and then the modern day lateral mass screw fusion construct with polyaxial heads. So we've come a long way as far as how to treat things posteriorly with instrumentation. Standard lateral mass screw trajectories are described here. We'll go over this in the lab. That's actually going to be my station. And important to make sure that your screw trajectory is proper to avoid risk to the nerves and vascular structures around you, and these are the ideal screw trajectories, and we'll again discuss this in the lab. I have a nice way to help guide you with lateral mass screws, by assessing the trajectory of the facet joint, because that should be the trajectory of your screw. It's going to give you the biggest latitude as far as length of screw and decreased risk of violation of the structures around you. So, an en bloc laminectomy, I think, is ideal because it results in less use of the kerrison. So drilling troughs on both sides of the lamina and pulling it out en bloc, I think, is less likely to lead to injury due to less use of the kerrison. And so my technique is that I put my screws in first before I do the laminectomies, but these cartoons show the opposite, where the laminectomies are done first. So laminoplasty is well described. If you have pure myelopathic signs and you have, say, for instance, ossification of the posterior longitudinal ligament, one could consider laminoplasty. And laminoplasties are fairly quick and efficient, and they preserve motion, so that's something to consider. Better than a laminectomy because a laminoplasty preserves more of your anatomy. As you can see, this depiction is of an epidural hematoma that potentially could have been avoided if a laminoplasty was done as opposed to a laminectomy. However, furthermore, with laminectomy, there is a risk of post-laminectomy kyphosis, probably more common in the pediatric literature. But still, younger adults are also at risk of developing post-laminectomy kyphosis. It's been reported to be at an incidence of 21 to 50%, and depends on which lamina were removed, and it depends on the extent of facet resection and the number of levels that have been performed. Definitely, a laminoplasty helps avoid this to some degree, but most laminoplasty cases do result in a slight loss of lordosis. So fusion obviously would prevent this from happening, but not everybody should be fused. So these are the disadvantages of laminoplasty. It can result in neck pain, Sometimes you need to do a foraminotomy in addition to a laminoplasty, and the laminoplasty makes it a little bit more challenging to do a foraminotomy. You do get slight loss of lordosis. So if the patient is blessed with a large amount of lordosis, then you could get away with a laminoplasty pretty nicely. Again, the indications are varied, but for a patient that has minimal neck pain and pure myelopathic processes, a laminoplasty would be a good choice if they have good lordosis. So if they have a kyphosis, or a disease process where you need to do a deformity correction, laminoplasty is contraindicated. So these are the different techniques: unilateral hinge, which is probably the most popular. You can do a bilateral French door laminoplasty with a midline decompression, but there's a variety of things, and we could look at that in the lab as far as techniques once we're done with the instrumentation. And one of the most significant things to mention as far as laminoplasty is concerned is C5 palsy. You can potentially get a C5 palsy due to the drift of the spinal cord away from the ventral disease and the kinking of the nerve root as the spinal cord drifts back. So that's one of the biggest concerns for a laminoplasty. So moving on to the grading of the cervical spine myelopathy, it's been shown that cervical spondylitic myelopathy outcomes can be dependent upon what grade the patient's in. And in this study, the NURIC grade 2 patients did better than other NURIC grades. In this paper, again, the Modified Japanese Orthopedic Association scores were used to help predict outcome. And so it's been shown that there's certain types of myelopathic grades that do better than others. And what it really amounts to is catching the patient at an appropriate time when their myelopathy has not progressed to a point where there is permanent dysfunction of the spinal cord. If you catch them at the appropriate time and they have a fairly early disease process as far as the grading is concerned, that you potentially could have better outcomes. And so that has been so important that Chris Ames in his classification system uses the myelopathic grade from the Modified Japanese Orthopedic Association as one of the modifiers in the assessment of their classification system. So it's important to grade the myelopathy. And so as far as this is fairly new, this cervical deformity classification scheme, but important to go over the fact that there are a variety of different types of cervical deformity, and they've classified these deformity types based on the location and type of deformity. So going from A to E, A is a mid-cervical apex of the deformity. B is mostly basically they're trying to say that the type of deformity is going to be different based on where the disease process is located. So you could either be all the way at the craniocervical junction or all the way further down at the T1 area, and in this way, by classifying the type of deformity, all surgeons across the board will be able to compare their outcomes, in a way where we could say that yes, this is a type A or a type E deformity. Type E is, who in the audience knows what the type E abnormality is? Where do you think that patient has a problem? Say that again. Yeah, so this is a craniovertebral junction abnormality. This patient has a problem with the clivoaxial angle. So the clivoaxial angle is more than the standard 120. So in that situation, there is more mechanical stress at the craniocervical junction. So important to look at, because you might just look at that superficially and say, oh yeah, that patient's got fairly reasonable cervical lordosis. Where's the problem? That's a separate sort of process. So if you look at this deformity classification thing, that's the very bottom, craniovertebral junction deformity. So that has to do with the clivoaxial angle and something to just remember. So, there's deformity measurements that the same way we look at sagittal balance with the thoracolumbar spine. You can get your cervical C2 to C7 sagittal vertebral axis, looking at the distance between C2 and C7 and measuring that distance. The chin brow vertical angle is another measurement, and the T1 slope minus the C2 C7 lordosis, that's another measurement. So all of these things are going to be incorporated into this classification scheme, and the degree to which these things have been corrected will be a mechanism through which we can assess how good patients have done after surgery, and especially in the correction of deformity. So, there's still a lot of work to do as far as how cervical spinal deformity is treated. This is a recent article from Justin Smith that basically looked at 18 different cervical spinal deformity cases and showed it to a panel. They showed these 18 cases to a panel of 14 surgeons. And there was a very significant lack of consensus on what disease, on what number of levels should be treated, what approach should be used. There still is no clear methodology on knowing how to decide, or what levels to fuse, or what types of osteotomies to perform. So this is work in progress. So we'll go through a couple cases. As you can see, this is a gentleman who presented with osteomyelitis and discitis that has resolved. He's no longer infected. He is a gentleman who developed this in South Africa and then moved to the United States. And he had a hip fracture, traveling and was doing some kind of safari, and developed this hip fracture and got multiple transfusions and an infected hip, and with explantation, and he developed an infection and became systemic. He survived this in South Africa and then came back to his home in Maryland. And ended up having this disease process there. So he had a C3 osteomyelitis with significant kyphosis. You can see the AP distance of the spinal canal is 5.8 millimeters, so he's got stenosis and generalized weakness. This was a fixed deformity. The flexion extension films didn't show any movement. So you can see that he's got that bad deformity there at C3. So what kind of approach would you recommend for this disease process? Yeah, anterior. So how many levels? Yeah, so 2 level. So do you think it needs to be backed up or not? Yeah, I agree. So this is a situation where you may think, oh well, maybe I can just distract between C2 and C4 and try to pull that C3 vertebral body out and drill it out, but it's not going to happen. This is all ankylosed. It's like a big rock. So you need to drill out C3 and C4, and address those two levels, and C2 is hard to get solid fixation in C2 from the front, so this should definitely be backed up. This was the final product. You can see that this type of cage has integrated fixation into the top and bottom, and allowed for a correction of the kyphosis and replacement of the anterior column height with the posterior fixation. And this gentleman did very well after his operation. All of his myelopathy, improved substantially, and his motor strength improved, and he's ambulating, and he was then, he had no hip. That was his main problem. And the reason why we did this surgery was so that he could tolerate, further surgery, and so he finally got his hip, and so now he's very happy, and he's walking around. So this is another interesting case. Quickly, I'll just tell you her history. She basically had a C3 to C7 laminectomy for a trauma, many years back. And she did well after this trauma, but she slowly started to develop cervical kyphosis. She was actually seen by one of my orthopedic partners at shock trauma, and they were following her for a little bit, but then she got lost to follow-up, but wasn't incredibly symptomatic at this point in 2014. But one of the things you may notice is that AP spinal canal diameter on the axial images is pretty small, so that was her situation there. She was fairly neurologically intact at that time. This is what her C-spine CT looked like at that time. So you can see she's got some kyphosis, but she was pretty much asymptomatic, so nothing was done. So she represented in 2 years later, and unfortunately she developed bilateral lower extremity paresis, and waited at the outside hospital for several days before she got transferred over to the university. But she arrived with weakness in her legs, no weakness in her arms, just weakness in her legs, and had incontinence. And this is her exam. This is her C-spine MRI. You can see she continues to have that severely flattened spinal cord. It's very abnormal, and she has developed, because of her lower extremity weakness and absence of upper extremity weakness. We were thinking that perhaps she could have some kind of thoracic disease process, but her thoracic spine was normal, as was her lumbar spine. So you can see that the extent of kyphosis progressed from 2014 to 2016. This is a case of post-laminectomy kyphosis. And this was a non-reducible kyphosis. She had flexion extension films that showed no movement. So what we ended up doing was basically an anterior posterior, and this was an intermediate CT that shows just after the anterior release. These are interbody cages with a hyperlordotic option. 12 degrees of lordosis is achieved through these interbodies, and you can see that we got some improved correction with that interbody, and I only put in one screw in these interbody cages because that way you have a little bit of leverage from the posterior approach as far as further correction. And you can see that you start out on the left with the pre-surgical kyphosis. The middle one is the intermediate stage without posterior fixation, and the final one is with posterior fixation. So you can see gradually we had some restoration of lordosis. she still has a straight spine, but I was worried to correct her completely, mostly because of the fact that her spinal cord was so incredibly flattened, and I was worried that there's so much scar tissue in the posterior aspect from her previous laminectomy that if I corrected her too much, I was worried that I may have some buckling posteriorly that would create some kind of process that could compromise this spinal cord. So I tried to do it very gently and gradually, and didn't want to do too much. So she's actually doing much better. She's regained her continence. Her motor power in her legs is now 4 out of 5, and she's substantially improved and is continuing to do so. So in summary, important to know the difference between spondylosis and stenosis, and to realize that it's incredibly common. We need to check for myelopathic signs on exam. We need to catch these myelopathic patients early in order to get the best outcomes. And early surgical intervention may potentially improve patients with myelopathy. The type of surgery and approach to surgery, depends on a lot of things. A lot of the time it depends on what the surgeon feels comfortable doing, but that shouldn't be the only thought process. You shouldn't just be a posterior guy or just be an anterior guy. You should really see what the patient needs and come up with a treatment plan that is most appropriate. And you got to realize that these patients in whom you're doing these complex deformities, they need to know that these things are risky and that potential complications may arise, and adequate counseling will best prepare them for this, as well as future surgeries that they're going to need, because we all know that adjacent segment degeneration is real, and if these patients are active, they will develop it over time.